Good afternoon, everyone. Thank you for joining us for session 2 of our 3-part series, Healthy Eating, No Time, No Money, No Time, and Healthy Eating Quiz. My name is Phoebe James, and I'm a Professional Development Officer with the Hunter New England and Central Coast Primary Health Network. Before we begin, I would like to acknowledge the traditional custodians of the lands that I live and work on. Here in Newcastle, it's Awabakal and Worimi land. Pay my respects to elders past, present, and extend that respect to any First Nations people joining us today. I just want to mention before we start that this is being recorded. The recording will be available in the Education Library on the PHN website and on the DAP Plus page, but Alexis will take you through that in the next week or so. We do not permit AI note takers to be used in our webinars, and you will be removed from the session if you are using one. At the end, there's a short evaluation. If you can complete that, it gives us really valuable feedback that helps us form future education events. At the end of the presentation, we'll have a Q&A session, so please put your questions in the chat, and if we have time, we will cover them. It's now my pleasure to introduce our wonderful facilitator, Professor Alexis Hewer, Research Director for the Diabetes Alliance Program Plus. Thank you, Alexis.
Thank you, Phoebe, and thank you everyone for joining online today and for those who watch after the event. So as Phoebe said, my name's Alexis Hewer and I work in the School of Medicine and Public Health. I'm also an accredited practicing dietitian, and I really look forward to chairing the session today on the Diabetes Alliance Program Plus Healthy Lifestyle Tools, particularly the nutrition tools. So just to give a little bit of background about the Diabetes Alliance Program Plus before we start the session, and I will just build upon what we've covered in the previous week. So rather than go through this slide again, I'd like to talk to some of the outcomes of the program to date. So the program's been running for 10 years now, and over that time, there have been 8,000 case conferences that have been delivered in primary care. And there have been, the specialist team have attended over 200 general practices and 13 of the 14 Aboriginal medical services across the Hunter New England Local Health District. Outside of that, there have been education masterclasses that have upskilled thousands of primary care clinicians. And so as a result of all of that upskilling, what we know from the case conferencing is that after the initial visit, at the 6-month follow-ups, we see a mean reduction in HbA1c of 0.8% in just 6 months. So that's really fantastic outcomes. So in terms of the program, hopefully many of you are very familiar with it, have participated. One way of participating is to take up these healthy lifestyle tools that we are promoting here with the PHN today. But you can also have a look at the DAP Plus website and express your interest in joining the program as well that way. So just to briefly move on and say this is the second of the healthy lifestyle tools in our series. We'll be speaking. We've got a wonderful speaker today for healthy eating. Last week we hosted the Being Active session with Professor Ron Plotnikoff. And next week, we'll be hosting the Healthy Wellbeing Tools with Professor Francis Kay. The recording of last week's session will go up on the PHN website, hopefully later this week or early next week. So just give us a little bit of time to pop it up there. We'll also post a link to it on the DAP Plus website. But now, without further ado, if I can progress my slides, thank you. I would like to introduce our wonderful guest speaker for today, Laureate Professor Claire Collins AO. Professor Collins is Head of Nutrition and Dietetics at the University of Newcastle and Director of Nutrition and Metabolic Health Research Program at the Hunter Medical Research Institute. She was appointed Officer of the Order of Australia in 2023 for Distinguished Service to Health Service in research in nutrition and dietetics, scientific organisations, and science communication. Professor Collins is a Fellow of the Australian Academy of Health and Medical Sciences, Nutrition Society of Australia, and Dietitians Australia. With more than 600 publications and having supervised 50 PhD candidates, Laureate Professor Claire Collins is in the top 1% of all nutrition scientists globally. And I can personally attest to this, having been one of Claire's PhD candidates 2 decades ago now. Claire, can you believe that? So Professor Collins is also the wonderful DAP Plus lead for the nutrition component, and she is supported by an amazing team, which includes Dr. Roberta Asher and Dr. Rachel Taylor, who have really worked hard to facilitate the integration of the nutrition enhancements to the clinical program over the last 3 years. So with that, I thank you very much, Claire, for taking the time to join us today, and I will hand over to you now.
Thank you, Alexis. And I'll share my slides. I'll just wait for you to unshare. Thank you, everyone, and thank you for the opportunity to present on the work that we're doing in nutrition for the Diabetes Alliance. Can you do a thumbs up, Phoebe, if that's come up okay? Brilliant. Okay, just working out where to move things on. There we go. So 7 million Australians, that's 1 in almost 4, live with at least one diet-related chronic disease. 10 million, more than 1 in 2 Australians, have more than 3 cardiovascular disease-related risk factors, and 25% have more than 2 chronic disease risk factors. So the learning goals for today, there's 5, you can see them there. Let's jump straight through. First up, looking at the importance of optimizing nutrition for diabetes. Well, I want to show you what the consumer nutrition education model is. It's the Australian Guide to Healthy Eating, and it's designed to lower population level diet-related risk for chronic disease. And it encourages us to eat more of the foods that are on the plate. They're called core foods. They're nutrient-dense foods. And to limit those that I've circled in red. They're called discretionary foods. They're energy-dense and nutrient-poor. And if we could wave a magic wand and all of a sudden every Australian ate exactly like the Australian Guide to Healthy Eating, the diet-related disease burden would drop by 50% for heart disease and 26% for type 2 diabetes. This is huge. So any step we can undertake to help people eat just a little bit better will go a long way to reducing the diet-related disease burden. When it comes specifically to dietary recommendations for diabetes or pre-diabetes, I've taken this slide from the American consensus report because it sums really nicely what the evidence shows for a range of dietary patterns and what particular aspect of care will change. If you look at the Mediterranean style diet first, you can see studies show it lowers the risk for diabetes, it lowers HbA1c, triglycerides, and the risk of major cardiovascular events. And if you scroll down, what you can really see is that there are many, many dietary patterns that can prevent or improve diabetes-related risk factors and health outcomes. So it means that for the individual patient, there's actually a choice. There's no one particular diet that's going to improve their health. Things that might be relevant is whether there's a time or health urgency needed for health gain improvement. And what I believe is missed, so I actually quoted myself there, is that often the dietary approach is not altered over time. But if someone's finding or fatiguing at one type of approach, then you easily could support them to move to another. And why does that matter? You heard Alexis say that the mean impact of DAP Plus is a 0.8% reduction. every 1% reduction in HbA1c is associated with a 14 to 7% lower risk in myocardial infarction, 37% reduction in microvascular complications, so that's eye, kidney, nerves, and a 21% decrease in any diabetes-related endpoint or death. So when you're talking to a patient, even if it's a part of a percent, their HbA1 improvement, this is really, really big deal for them in terms of health outcomes. So what are the barriers and facilitators then to getting nutrition support? I'm sure everyone's aware that people living with diabetes should have an annual cycle of care. And in that document, it says that at least annually, you should review and discuss diet. And it can be provided pretty much by anyone, which I think is a tragedy, but it can be provided by the GP or the accredited practicing dietitian. So today we're going to show you how you can use the No Money, No Time website to ensure that you're helping people achieve those reductions in HbA1c. I want to show you some rather stark Medicare usage data first. On the left, you will actually see 20 years data of Medicare subsidized allied health visits. And number one at the top is podiatry. Number two is physiotherapy. And all the rest of us allied health are bunched up down the bottom. But if we expand this big red box, and that's the slide on the right, you can see, well, first up, you can see the big dip in all services during COVID. But if you have a look at this, the services for dietitians, which is in the blue, decreased during COVID and has not made it back to pre-COVID levels. There are very few referrals to dietitians, despite there being a care plan model that would actually allow referral under Medicare. And if you look at use of Medicare-funded dietetic services, specifically for newly diagnosed diabetes, and just in New South Wales, this does look a little bit more promising. But if you can see, there's only 2% who actually have had 5 or more claims for dietetic services. So dietitians, as is all allied health, are very underutilized. So we've done surveys of patients, of clinicians, in terms of what are the barriers and facilitators to actually seeing a dietitian. And so for patients, they tell us getting a referral. That would actually mean they would be more likely to see a dietitian. Having appointment flexibility, so the use of telehealth would make a big difference, and their individual level of motivation to change their dietary habits. So if you see someone who's motivated, then referring them to someone who offers online service is a big plus. One of the barriers, of course, is the cost. Again, why a Medicare plan is really important, but will cover what is free under No Money, No Time. Then when we looked at what the patient and clinician facilitators and barriers to medical nutrition therapy were, again, it was getting a referral was a motivator, appointment flexibility. Oh, sorry, that's actually the patients, which I've just showed you. If you have a look on the right-hand side, these are actually the factors. So knowledge of what the value of medical nutrition therapy is. If people don't know what we do, they're less likely to refer. Hopefully we're addressing that today. And then the patient attitudes towards the dietitian. If it's positive, then they're more likely to accept a referral or be referred by you. And you can see that there. Then the key barrier for diabetes, I forgot what I was going to say there. Patient attitudes. This is really highly experienced by practice nurses and diabetes educators. If the patient has negative attitudes towards seeing us, then it's a barrier. So let's have a look at how we can address those. And I just put in a few points as a checklist on how you might address these. talking about no money, no time in the healthy eating quiz as a starting point. Don't need to go and see a dietitian face-to-face if that's challenging for the patient or they initially have a negative attitude to our profession. Targeting their motivators to changing their dietary patterns, which we address in the healthy eating quiz. The cost of food in healthcare, again, no money, no time can address that. Helping you being able to sell the value of nutrition reviews. And then I'll comment at the end on when it's appropriate to refer to a dietitian. So now we're going to start by focusing on how you can use these freely available resources in order to be able to support patients in achieving goals before they get to the point of needing a referral to a dietitian. When you ask someone, do they usually eat healthy? The most common answer is, I think I usually do eat healthy. But the reality is that no one in Australia usually eats really healthy. So I'm showing you now, this is the Australian Guide to Healthy Eating. And if you did eat like the recommendations in the dietary guidelines, then about 85 to 90% of your total energy would come from these foods on the plate. They're called the core foods, those nutrient-dense foods. But average for Australia is 60 to 65%. And the discretionary foods, which in an ideal situation would be 10 to 15% of your total energy intake, they actually make up 1/3, and for some people, more than 1/3. And I added salt intakes because this is relevant for hypertension, is that our salt intakes are about double the suggested target. And what we know, though, is that if you do eat more like the dietary guidelines, these are results from a review I did many years ago, and subsequent reviews have showed the same thing. That when people eat like those dietary guidelines in their own country, they do achieve what the objective is. Eating more like your country's dietary guidelines is associated with a marked lower risk of all-cause mortality, heart disease mortality, heart disease risk, cancer mortality, and all-cause cancer risk. So anything we can do to support people makes sense. So when I did that review, I thought, well, what if we could create a one-stop diet quality score that would allow people to say, do I usually eat really healthy? Do I eat like the Australian dietary guidelines? And I developed a tool called the Australian Recommended Food Score, initially intended for research. And I developed that in the Australian longitudinal study on women's health using data from 30,000 women. Subsequently done multiple validation studies. They're available at the Australian Eating Survey link. And this tool has been used in 140 studies now, across 50 institutions in 10 countries, to look at these associations between diet quality, health and wellbeing outcomes. And it was this that prompted me to adapt it so that you could use it, so that patients could use it. There's some of the key publications down the bottom. So this is how that development went. At the university, with support from TUNRA, I developed an original online tool for the healthy eating quiz. Version 2 appeared very quickly because I had not catered for vegetarians, and also saw that we needed some cut points and to give people more feedback was what they wanted. In 2016, we extended the age categories down to age 3, and I've done validation studies in that. And we added some updates. In 2019, after receiving major philanthropic funding from the NIB Foundation, we updated the user experience, created new features, and included population normative data. And it became incorporated then in a website called No Money, No Time. This is what No Money, No Time looks like. The Healthy Eating Quiz is up there in the right-hand corner. And when you click on that Healthy Eating Quiz and undertake it, this is what you get. We tell people it takes 10 minutes in case they're not good with IT, but really it takes about 5. So they get to see their score relative to the population norm. And this is important because remember I told you pretty much no one eats like the dietary guidelines. So this helps you feel a bit better if you're at least above average other people in your same age or sex category. And this is what it looks like if you do it on your mobile phone. And there's the QR code. The first thing that happens is you see a login page. We do need your email because you will get automatic reminders to come back and retake the quiz over the next 3 months. And this is what that personalized report looks like. You can download it. You can save it in your own in your own profile page, and you get an overall score page and some suggestions. And then you get the same thing for each of the subscales, whether it's vegetables, fruit, grains, dairy, water, or condiments. But No Money, No Time is more than just the healthy eating quiz. It gave us an opportunity to provide people practical resources to improve their diet quality and to help them see how they can save both money and time by eating more healthily. Let's go through each of these tabs. With the recipes, there's a huge range of filters that allow people to personally tailor the search. You can search whether you're a vegetarian, gluten-free, dairy-free, whether you don't eat fish, etc., down here, and then whether you want to cook for 1 or 2 people, or you're cooking for 3 or more, or you can even search the recipes based on the cost per serve. You can use the diabetes-friendly filter to further refine the search. There's also a heart-friendly filter as well. And then you can search if you just want dinner recipes, snacks, breakfast, lunch. You can also search based on what equipment you want to use, an air fryer, a microwave oven. People tell us repeatedly that ovens actually never work, particularly in rental properties. And then this is the motivators filter. This is what I think you can use with your patients to provide that motivation for wanting to improve their dietary patterns. And I've exploded those out. These motivators, we've added like diabetes friendly, but they originally came from what the people we worked with in the co-design of this website said. They don't always want to be healthier, but sometimes they want sharper thinking, better sports performance, healthier skin, a healthier gut. They want to feel fuller for longer or have more energy or have a better immune function. These will vary by the person, but these then gives you clues onto what to follow up with them over time. In the hacks and myths tabs, we have many, many articles related to diabetes and heart health. And many of these articles, the suggestions come from the users of the website. And we try to be very responsive when people request new information. And then here's some more examples of diabetes-specific articles, and I'll come back to this. Then in the resources, ebooks, and meal plans, we have things like a salad builder, a pizza builder, showing people how to get the fundamentals of easy meals to make. And then, of course, in the resources, we have the podcasts. We have downloadable ebooks, including one on diabetes, and then meal plans. The most clicked on article in No Money, No Time is this one, which probably actually needs a cost of living update, how to eat for $60 a week. And the idea behind that was just to show people that you might not even choose all those recipes, but that it is possible to save money if you're able to plan ahead. The way we've used No Money, No Time to try and promote engagement with the resources is through what we call 6-week email campaigns. And we did a diabetes specific one, and the results are in preparation. And it was linked last year to our nutrition promotion and advertised through Diabetes Alliance. And what these challenges have achieved in 6 weeks, people have improved their healthy eating quiz scores by over 3 points. They've been able to reduce household spending on takeaways around $8 a week, reduce body weight, even though that wasn't a goal of the campaign. And we've seen that the open rate and click-through rate are 2 to 3 times greater than the sector average, including the health sector. We've published many of these papers, and again, you'll have this slide as a PDF, or you can reach out to us if you want copies of them. So do people like No Money, No Time? Well, 1.2 million website visits tells us they do. 2 million page views, 1 million healthy eating quiz completions going back to way before No Money, No Time, 670,000 active users, and so on. But that 350 organizations are now linking to this is really important. We have a closed Facebook group, so any of your clients who need more support or want to talk really specific stuff about recipes, they can join that Facebook group and post their comments. So now let's really make sure everybody knows how to use No Money, No Time and the Healthy Eating Quiz. To achieve that, we created a one-pager. We've created a black and white version of this for primary care practices. We will add that to DAP+. It's currently on No Money, No Time. So it's easy to do a one-click, one print and not use up all your color. But this QR code will take you to this resource. And it's designed as a step-by-step self-help resource for people living with diabetes that you can see. And this is going to help you help motivate them to improve their nutrition. And likely you're going to end up talking about nutrition quite a bit. So those QR codes, you'll also find them on the Diabetes Alliance webpage and in the 3 resource modules and their QR codes. So you don't have to worry if you go, oh no, you removed the slides and I didn't get the QR code. They're there, and if you can't find them, we'll send them to you later. So you've printed off the black and white version, maybe, hopefully, or you can print the color one, or you can just send the person to the QR code. What are they supposed to do? Well, they click on each of these if they're looking at it online, and they'll go through directly to these resources. So the first thing we ask people to do is to read our hack and myth about what do eating patterns have to do with diabetes in the first place. Then we ask them to take the healthy eating quiz and set some goals, which you actually do at the end of the quiz. So I created this little flow chart of what it looks like when you do the quiz. Remember I said you've got to put your email in first, tell people that, otherwise they go, oh no, you've got to put in your email. Then it tells you to get started, and then it's, if you can see it, what's your main reason for taking the quiz? There's a few extra ones there, and one of the really common ones that people click here is because they want to feel better in themselves. So remember, not everybody is doing this for their health, but feeling better in yourself is likely to happen when your health is better. Then they'll fill in all the questions. They're set out so that it's point and click. Then there's they get their score report. Then they can save or email or the report to themselves or download it if they want to. Then there are extra questions. We ask them, how did they hear about the Healthy Eating Quiz, so that we can monitor if they're getting it through the Diabetes Alliance. And then they're asked to set some goals. And these are a low bar, but this is realistic on what people can do. So let's say worst score was in vegetables. The maximum score in that scale is like 19 points. What if you only got 5? Maybe an appropriate goal would be to try and eat 2 different vegetables in the next week. And then once people have achieved them, they can click that goal and set a new one. And you might think, oh, that's not much of a change. Well, it's small changes that add up over time. And I've included a snapshot of the logout. You know how it can be so frustrating because you can't then get out of a page? The logout is at the bottom. So the 2 key barriers they might go is, oh no, you've got to put in your email, and I couldn't find the logout. So that's being clear on how to get in and out of the quiz. Then the next thing in this self-help flowchart is to download the diabetes free ebook on food, cooking, and diabetes. And it has lots and lots of really useful information. People may opt to print this black and white if they're printing it at home, but it looks a lot better in color. And it's got all information about SMART goals, decoding labels. What are the pantry staples that if you actually had in your cupboard, you'd be able to put together a cheap meal faster than Uber can show up at your door. And then we've got a whole bunch of cooking, grocery, and shopping hacks just to take the headache out of the planning. Because for many people, they'll tell you that it isn't even actually the cooking, it's knowing what to cook and then having those key ingredients already in your cupboard. So you can use this flyer to guide people through their no money, no time journey and really utilize the resources. Of course, there's many other resources that they're very welcome to use, but these are the key ones for diabetes. And this is just a reminder about that filter will take them to the diabetes friendly recipe filter. And I've already told you that about the other motivators they might want to select as well. So then the next tab is the podcasts. And so far we have 5 podcasts specific to nutrition and diabetes. You might go, wow, I didn't know there could be 5 topics on that's worth talking about. Well, there actually are. We've got another one coming up in Diabetes Week as well. But if you're talking to your patients all the time and there's something really specific, they keep asking about nutrition and you don't know the answer, just let us know. We'll make a podcast and a resource. And then again, just a reminder, I hope I've reminded you enough about where to find the QR codes and find the links so that you don't have to think about or worry about whether you've captured the QR codes today. We've also created another patient handout on the No Money, No Time website so that if people who aren't belonging to DAP come along, we can refer them into making sure everyone's getting the same information about nutrition and diabetes. And on that one, we put a direct QR code to each of those sections on the website. So I hope that's shown you and that you feel a bit more confident about using the No Money, No Time website and the Healthy Eating Quiz for supporting people with diabetes. So now we're going to cover how do you measure then the impact of improved nutrition on diabetes control? Well, I think it's more than HbA1c. You know, when we looked at those barriers and facilitators at the start, I think this may be different for every individual patient. So you can use this checklist because when the person comes back to see you, it's really helpful if you have more than one outcome that you can talk about. And I purposely put body weight last. Anyone who's stood on the scales more than once in a day knows that body weight can vary hugely in a day and even from day to day. So let's not hedge our bets on nutrition patterns only being marked as effective if someone's weight's changing. There's so much more you can look at. So you can look at the Healthy Eating Quiz score. If you boost your score, that's a big change in your day-to-day behaviors. Having better well-being, being able to move more or reduce your pain. There is actually a podcast on nutrition and pain for any of your patients who are living with osteoarthritis. Are they feeling more motivated to engage in healthcare over time? That's a big predictor of health outcomes if they keep coming back to see you. Is blood pressure going down? What about fasting glucose, HbA1c, time in range if they're wearing a CGM? Lipids, triglycerides, inflammatory markers if they have an inflammatory condition, liver function, rate of progress of renal disease, continence, sexual function, waist circumference, belt or clothes size. But I really do think that body weight is at the end, and make a conscious decision to focus on non-weight related outcomes to support your patient in engaging and improving their nutrition. So remember at the start, I told you all those other dietary patterns that have been reviewed in the consensus report. I haven't talked about them because once people want to engage in a very specific diet, this is when they may well need help from a dietitian. But every one of those dietary patterns, actually at the core of them, is eating more vegetables, fruit, and whole grains. And then they overlap in terms of which other core foods they promote. Some of the patterns are vegetarian and focus on more beans and legumes or nuts and seeds, or the Mediterranean diet focuses more on olive oil in terms of fat quality. Other diets not on that target have additional aims. The Heart Foundation and the DASH diet target a sodium reduction. Remember, I told you the average Australian has double the amount of sodium and salt. And weight loss diets, if it's really the main goal is weight loss, there will be a kilojoule reduction target. That's tough. So I've put in hierarchy and show you where No Money, No Time and the Healthy Eating Quiz. If you think about people achieving a stepwise increase in effort to eat more healthily, if we look at the people who are way, way below the average Australian dietary intake, or even average, doing the Healthy Eating Quiz and using No Money, No Time is going to help them eat more like the Australian dietary guidelines. And this is really where No Money, No Time fit in. But I'll tell you about these three named dietary strategies. They're going to be more effort than than trying to follow the Australian dietary guidelines, and people will need more support. A low energy diet and a very low energy diet are two dietary approaches where I strongly believe you need to refer people to a dietitian. Let me show you why. A systematic review of does it matter if you send someone to a dietitian? Let's look at all the studies that compared dietary advice provided, which we call medical nutrition therapy by dietitians, compared to other health professionals. This is a meta-analysis result. It led to a 0.45 greater reduction in HbA1c, 0.17 LDL, and 0.55 in BMI units. But if you remember back to that first slide I showed you about how much does HbA1c, this is equivalent to an 8% extra reduction in the risk of myocardial infarction, 18% reduction in those microvascular complications, eye, kidney, nerves, and 10% extra reduction in any diabetes-related endpoint or death. So when you have someone who's really struggling with their nutrition, do you think they would think that's of value then to see a dietitian? I think this is a really helpful way to think about who you refer. Now I'm just going to quickly tell you about what's a reduced energy and the other two. Reduced energy diet is a dietary strategy that's been used in most of the GLP-1 trials internationally. I know this because we reviewed those trials and looked at the dietary interventions. And what a reduced energy diet does, it works with individuals to try and identify food patterns that could be a swap, and you would automatically lose 2,000 kilojoules. You could magically make them disappear by a food swap. That's about 500 calories. The easiest one to explain is this. For someone who drinks 3 cans of soft drink a day, that's around 2,000 kilojoules. If you swap to water, magic, 500 calories has disappeared. If you buy a choc chip cookie at any of the cafes that are about the size of a saucer, if you swapped to 2 small cookies out of a packet, you would again save around 2,000 kilojoules. And if you swap from a big plate of spaghetti bolognese to quarter your plate as the pasta, a quarter as the meat, and the other half salad or veggies, again. But to do that, people have to learn about kilojoules, and not every patient will be ready to learn about kilojoules. And I've just included a few other strategies there to achieve a reduced energy diet. A low energy diet is when there's a daily kilojoule target, because the goal is actually weight reduction. And for this dietary pattern, typically there'd be 6,000, 7,000, maybe 5,000. It requires people to self-monitor. The systematic review, so self-monitoring works, especially when health professionals give the patients feedback on the self-monitoring data. But for some people, they might say to us as dietitians, you know what? It's honestly been so long since I've eaten in a structured way that I do not know what 5, 6, 7,000 kilojoules look like. A trial of a home delivery kilojoule controlled diet pattern can really help someone reset their balance, and it can also give them a mental break from thinking about what to eat. There's web programs, group-based programs, online programs, health fund programs, always check your health insurance, and individual counselling from a dietitian. And then a very low energy diet. These are used when metabolic health drastically needs to be improved. And these should only be under the supervision of GP and dietitian. They're typically ahead of bariatric surgery in order to shrink the liver size and liver volume to reduce surgical risk. They use proprietary formulated meal replacements, and they're being more and more used in a range of abdominal surgeries. So how can we then help people take steps forward in terms of improving their nutrition-related health? I think number one, we've got to ask about barriers, facilitators, and motivators, address barriers, recognize motivators, and use those to help with the facilitators. Identify that person's health and well-being goals. Start by assessing diet quality using the healthy eating quiz, and this is all in the self-help, but with reinforcement from you. Encourage small nutrition goals, self-monitor, review progress, and it's likely that you may need to step up or even step back down at some stages. We do have a tool called, it has a cost, which is why I didn't include that. It's called the Australian Eating Survey. We've provided a discount code so that people can get a 50% discount if they need their micronutrients assessed, or if they need to know what food group their kilojoules are coming from. We have 2 studies about to start. These are going to be advertised on the DAP Plus website and the PHN website, and I've put in the contacts. This is diabetes nutrition. This is for people who are using GLP-1 therapies, who might want to have that trial of medical nutrition therapy support. And this one is we're actually comparing acceptability of using technology tools compared to old paper-based diet for dietary monitoring for people who are doing blood sugar measurements. So in summary, the best dietary intervention to optimize nutrition and diabetes-related health outcomes is one that a person can follow. It's nutritionally adequate. It addresses any side effects of medications if they happen to be on medications, which they will be on some medications most likely. They're supported to implement it by all of us. It improves their health and well-being, and importantly, it's reviewed over time, especially in that first year of care before they move into the annual cycle of care. Take-home messages: evidence confirms that dietary impact obesity and cardiometabolic health. Support people using No Money, No Time, Healthy Eating Quiz. Keep in mind there's that hierarchical approach to improving diet, and you can step up and step down. Refer to an APD when medical nutrition therapy is needed, and those regular reviews again. I'd like to finish by acknowledging everyone, particularly NIB Foundation, who provided our first 6 years of funding, the Heart Foundation, who are our current partner on No Money, No Time, the Diabetes Alliance, who are providing the support for the nutrition arm of DAP+, and then all of my team who are mentioned on these, in particular, Dr. Roberta Asher and Dr. Rachel Taylor, and Elise Jones, who's our program manager, who just magically makes all things happen. So we can now move to questions.
Thank you so much, Claire, for a really outstanding presentation. And there's a bit of love coming through on the chat already in terms of recognising how valuable the topic is across a range of healthcare providers. So one of them actually says, from Meredith, absolutely fantastic presentation. I wish I'd known about this program earlier. As a pharmacist, I target all the preventive measures when I counsel patients. I discuss nutrition, sleep, sunshine, stopping smoking, exercise, mental health, etc. Before I discuss medication. I've always had an interest in diet and nutrition and had weight management program within the pharmacy, and then become a personalised trainer to be able to prescribe exercise for customers and patients. And you get great outcomes with blood pressure being reduced, reductions in sleep apnea, and lots of other health outcomes. So I think that's a fantastic comment to kind of launch from, where people can see the really practical side of these things, how nutrition plays a really important role across chronic conditions, and also how healthy lifestyle fits together, I guess, all of these particular behaviors. So thank you so much for breaking it down and making it really practical and giving us tools for something that can feel quite complex and overwhelming. So please, audience, do pop your comments in the chat that we can respond to. But if there aren't any other questions to go with to start, I would actually really love to ask you, Claire, about we've talked about this in the context of diabetes today, but these tools seem really practical and appropriate for lots of people. Are they applicable to other chronic conditions? What's the scope of the use of these tools, do you think?
Yeah, they absolutely are. And I think that's why the Heart Foundation have now come on board as a partner. They're also applicable based on life stage. One thing that we found interesting is that originally No Money, No Time was created to target young adults. And they came up with the name, by the way. They said, oh, we're interested in nutrition, but we've got no money, no time. Can you solve it? And what we found, though, is that the audience has morphed to include more older adults as well, and all of those non-government organisations and GPs using it. And we do prioritise adding content if they ask us. So it absolutely is. I think I showed you in research, the Australian Recommended Food Score, there's like 140 papers. We know that improving diet quality reduces chronic disease risk factors and improves outcomes. But the reality is that we hardly ever tell people how to do that. And, I'm just going to keep talking, Alexis, because one of my bugbears that I think is worth mentioning is that we really do need to support people. When you see the evidence, I showed you the slide about all of those risk factors that prove, we've got to keep in mind that the intervention in those, people are getting counselling support and the dietary strategy. So if you just hand the dietary strategy, you're actually relegating people to the usual care placebo control group. So self-motivated people can do a lot of this stuff themselves. We play a big role in improving people's motivation to engage in their own healthcare. I see that as a really important thing for us. But when you're part of a healthcare team, I think we all get to that point where you go, this person needs more help. And so that cross-referral across our disciplines is what's going to achieve the end goal for the patient, which is health gain.
Absolutely. I couldn't agree more. And I think that having someone to be accountable to and someone who takes an interest in your health, it does provide that additional motivation beyond just being self-motivated. And I think in, many chronic conditions, there's already such a burden that goes along with those, whether it's, the cognitive load of, managing medications day to day, making appointments, all of those things can be quite overwhelming, and then adding something else in. But one of your healthcare professionals, giving you that prompt and that encouragement and that support and showing you that there are evidence-based practical tools out there that you can use in your own time and get comfortable with, I think makes a real difference. So thank you for providing those in a way that is free and accessible to everyone, which is amazing.
Yeah, and one thing I could add, Alexis, when you look at the systematic review of self-monitoring, if someone discusses your self-monitoring results, so I know the podiatrists tell us they often talk about food, and we have a separate study with podiatry, but ask people about their healthy eating score, ask them what their goal was. When you see them next time, ask them how they're going. Have they got a favorite recipe? And that will help them to re-engage. And, providing that support in the conversations you're able to have will make a massive difference.
Fantastic. And I think you touched on a really interesting point there about podiatrists having nutrition conversations. So I think given that we have got a primary care clinician audience online, this is a perfect forum to talk about, who can have nutrition conversations with people, whether they have diabetes or more broadly, who's got that permission? Can you give us permission, Claire,
Yeah, well, we've given you more than permission. We've given you the resources and the tools. So a lot of the hacks and myths address misnomers. And, Dr. Hayley Donnelly has done her PhD on nutrition in people living with diabetic foot ulcer in collaboration with podiatry here in the Hunter. And it was actually the podiatrist who told us. They have lots of conversations, but they also hear the misinformation, and they also hear that the person hasn't seen a dietitian for 10 years or, to discuss their nutrition. So I think the way we can support all of you as our allied health colleagues is if you hear a misnomer and you're not really sure, you can say, I'm not sure about that, and get the person to look at the list of hacks and myths while they're there and you're working with them. Or have we got a podcast on that? Do we need to add a podcast on that? And all on the same page. There's a lot of nutrition information. No Money, No Time is busting that.
Fantastic. So I guess just on that, there are so many nutrition resources available online, and sometimes it is hard to know where to look. What would you recommend if someone comes across something that they think is a great nutrition resource that they can't see any information on the No Money, No Time website? Is there an opportunity to reach out and kind of connect with the team?
Yeah, definitely. There is actually a little red button. I know Elise doesn't like us overusing it because if people blow out the number of comments, it's actually a massive headache for us. But you can just send us an email. I think I did have it on the previous slide, and make a suggestion. People also make suggestions through the podcast as well. There it is, No Money, No Time. Just send us an email and say, look, I've had someone ask about whatever, and if it's a short hack, we can address that pretty quickly.
Fantastic. And I can see Elise has very kindly shared it in the chat as well. So is open to hearing about, what enhancements might be needed. I think you did a fabulous job of showing us some of the studies that are coming up. Anything major in the pipeline for No Money, No Time or the Healthy Eating Quiz that you can share with us, or online campaigns that are coming up?
We'll let you know when the next one is. One we had planned has been delayed. That was going to target high blood pressure, just because we're going to align that with some new guidelines that are coming out. But we will let you know when they are. We're happy to keep running those, and all of the other interventions are funding dependent. But the good news is there's the 2 studies that people can refer to now. So any patients who are taking GLP-1s, and the reason why we're doing that study is because we're in our systematic review of people on GLP-1s, out of 41 studies, only 2 actually measured what people actually eat. I find that really amazing. So we're going to address that, and we're also going to consider nutritional deficiencies, which has been, we believe, has been overlooked. So that's a really important study. But the other one is around use of technology. I think we want to be confident that people are happy to use some of these smarter apps, because these newer apps actually do provide some of that feedback that makes it easier to self-monitoring. Some of the apps actually allow you to share data with health professionals. And let's face it, people are using CGM, so we know that they're getting confident with using technology. So we want to make sure that for our profession, we're able to recommend current technologies that work well for monitoring diet and lead to improvements in HbA1c, in diabetes-specific outcomes.
Fantastic. And Elise has just posted on the chat that there's an exciting online course coming soon, or courses. And has commented that the program should be advertised as a public health initiative. So I think that's kind of in the spirit of what we're doing here today through the PHN, and making sure everyone knows that these tools are available. They're accessible through the Diabetes Alliance Program Plus website. We will put links to join a study. So anyone who would like to refer patients, clients, participants to that study, please have a look at our Join a Study tab on our website, and send people so that they can be part of this new and exciting approach to learning about how to use better technologies and nutrition for GLP-1s. That is a hot topic right now, Claire. Can I check, just on that, we hear a lot about Ozempic, we hear a lot about Mounjaro or tirzepatide. These GLP-1 medications do change the way people eat. Are these tools that you've talked to us about today, so No Money, No Time, Healthy Eating Quiz, are they appropriate when people are taking the GLP-1 class of medication?
Yeah, they absolutely are. But there's one more resource in there that I would say is useful. So in the resources section, we have what's called a food and mood diary, and it doesn't have kilojoules on it, but I think we may adapt that. But I would encourage you to encourage people to monitor their dietary patterns, because when you look at the reports, people's appetites reduce down anywhere from to eating between just 20 and 50% of what they're eating. And I know from clinical experience that once someone drops below 4,000 kilojoules a day, which is 1,000 calories, it's almost impossible to meet your nutrient requirements. There are case reports of nutrient deficiencies. I don't think we should be pushing on to patient that everybody goes and gets all of their micronutrients, because there's been a pushback and there's a cost for doing that. But I think getting them to have nutrition support from a dietitian is really key. These are hugely expensive medications, hugely effective. You want people to have the health gain, so investing in the nutrition support. And just one anecdote, and this comes from a GP who told me that since talking to patients about their muscles and protein requirements, she's noticed a switch in how keen people are to see a dietitian. And one positive thing for my profession is I think people are recognizing our coaching role and our dietary assessment role, and moving a little bit away from, dare I even say it, thinking of us as the food police, which is the real, which is historically how our profession was seen. So think of us as the coach, sell us as the coach, and if someone's starting on GLP-1s, as soon as they scale up to getting those side effects as the dose escalates, get them to see a dietitian, or it may be that they can see them under the chronic disease management plan.
Fantastic. Yeah, I really love the focus on, improvements in terms of, what motivates the patient, but also those functional outcomes, and, just that reframing of what the focus is and how we can help and support and encourage, which is fantastic.
Yeah, and Alexis, just one other thing. So we did a trial up in the Tamworth area of that telehealth counselling, and one thing that was really encouraging to us, people were offered up to 5 telehealth visits, is we found that even after treatment had ceased with the dietitian, 6 months later, in addition to improvement in health, people's motivation to engage in their own healthcare was still elevated. So I think this is really key, and sometimes we forget that value of helping to improve people's health literacy and that engagement in their own health. So valuing the role we all play in helping people achieve their goals is really key.
Fantastic. And I think that message of empowerment of patients, we play a really important role in empowering people to manage their own health better. So I think that's a really nice place to finish up. There is just one more comment in the chat. I thank Elise again for posting some of the links through to the No Money, No Time website with the books and the meal plans. There's a question of whether you would be happy to share an email, Claire. So does Professor Claire Collins have an email she's happy to share?
It's best
through the team.
Yeah, it's best to contact me through No Money, No Time. I hope you believe me when I tell you, I think I get at least 200 emails a day, and sometimes I even don't get to like the important ones. So Elise is there at the end of No Money, No Time, and she's the go-to person for our team. So thank you.
Thank you for fielding that one, Elise. It's in there and it has been recognised. Very much appreciate that. Okay, so we are going to bring this session to a close on time. I'm going to say thank you very much to Claire Collins and her amazing team for the genuine enhancements that she has brought to the Diabetes Alliance program to make it a plus, and to empower all of the people out there who may have diabetes, may be at risk of diabetes, or have other chronic health conditions. So fabulous job today, Claire. Thank you. I'd really like to thank Phoebe James as well and the Primary Health Network for facilitating these sessions. All three of them, you do a brilliant job of being organised and keeping us running to time and having the technology all sorted out. So I genuinely thank you. And of course, to our audience who have joined us online or maybe watching in advance as well. So really appreciate everyone's time and engagement. Phoebe, I'll hand over to you now for the final wrap up.
Thank you so much. Just want to echo Alexis's sentiments. Claire, absolutely fantastic. And I really do think that in this time of the cost of living crisis, the fact that you've created such a useful tool that you can use every day. We're all time poor. We're all busy at work. We've all got busy commitments after work. I hope you're very proud of yourself and the team. You should all be very proud of yourselves because it's fantastic. I use it myself. I love it. Absolutely love it. Right. Alexis, just the best facilitator in all the land. Thank you so much for taking the time. Always wonderful. And to everyone who has joined us today, thank you once again for spending your lunch break with us. We will try and steal one more of your lunch breaks next Wednesday, so please join us and look after yourselves. Thank you so much.
Thanks, everyone. Bye.